the machinery that synthesizes the red blood cells with the help of some hematopoietic growth factor, right? Or any other chronic kidney disorders, like for example kidney disease. Kidney disease, you know, you all know, right? So alikati timarसँग interaction गर्न अलि अप्ठ्यारो छ है, तर still I'll try. Okay, kidney disease na, you know, you all know what erythropoietin is, right? By now, I guess. Erythropoietin has so erythropoietin which is synthesized from the kidney, right? Kidney peritubular cells photosynthesis. So any kidney defect can also lead to decrease in that erythropoietin hormone, and without the erythropoietin hormone, there is no synthesis of the red blood cells because it induces the erythropoiesis, right? And increased destruction. So I just grossly divide this, so hemorrhage or hemolysis, right? So today we are going to discuss the anemia due to nutritional deficiency, right? So two main types. There are different types of anemia, of course, right? So morphologically, and you can mainly we can classify it into microcytic hypochromic or macrocytic or megaloblastic, or this is also normocytic. Or also, you know, the normocytic normochronic anemia is there, which is usually in case of the like blood loss, hemorrhage, or say there is normocytic, normochromic types of things, you know. So iron deficiency. So this occurs due to iron deficiency, and megaloblastic occurs because of two main vitamins, you can say, or these are called maturation factors. Vitamin B12 or folic acid deficiency, right? So this you all know what. So just to trigger you again, right? This is the normal erythropoiesis, right? And what happens? So these are simply you can now right guess what we are discussing today from today, that hematinics भनेको यही तीनटा हो, iron, vitamin B12, and folic acid, right? Or folate. So what happens in iron deficiency, right? So this is the step. So this is the normal erythropoiesis, the steps, you know. And in case of what happens what can happen in case of iron deficiency, and what happens in case of these two vitamin deficiencies, right? So iron deficiency, you can see here the type of cells by now, right? There is microcytic or microcytic hypochromic type of anemia, you know, because iron is required for hemoglobin synthesis. No hemoglobin synthesis means the color decreases, so hypochromic, and the size, because less hemoglobin will be there in the red blood cells, so the size decreases, right? So that's why the hypochromic and microcytic types of anemia occurs in iron deficiency, whereas vitamin B12 and folic acid is required for DNA synthesis. So any deficiency of these two will lead to decrease in DNA synthesis, or there is defective DNAs are synthesized, right? And that can inhibit the cell multiplication. So cell multiplication, say inhibit see. Usually the cells which are formed, they are larger in size because the multiplication, proliferation that does not occur, and in fact the size increases, right? Because proliferation of the size, it's usually the pro-erythrocytes, the immature red blood cells are actually released into the circulation, right? There were these, you can see here, because iron is not affected, so the color is normal, so normocytic, and the megaloblastic types of anemia occurs in case of the vitamin B12 and folic acid deficiency, right? So simply by definition, hematinics, sorry, these are substances required in the formation of blood. You can define it in your own way, right? Basically, these are required in the formation of blood, and hence are used for the treatment of different types of anemias, right? So that includes these three micronutrients, right? So let us start with the iron. Sorry. So you all know iron, it forms the core, right? You can see this is the porphyrin hemoglobin chain, all right, the porphyrin ring of the hemoglobin chain, right? And you can see here the iron, it forms the core of this porphyrin ring, right? So this is actually you can see this hemoglobin concentration is a rate limiting step for erythropoiesis. So any no iron decrease in iron level means decrease in formation of the hemoglobin, and hence erythropoiesis is decreased, right? So total body iron in an adult. So alikati yo general I don't know in your biochemistry pani alikati hola. This will be a bit repetition if you have already finished in your biochem, right? So yes, 2.5 to 5 gram is the total body iron, right? Out of which you can see here, this is the distribution of the iron, right? So 66% is occupied by the hemoglobin. The 25% is usually stored as ferritin or hemosiderin. Hemosiderin is like aggregates of the ferritin, you know. We'll see what ferritin is again. Myoglobin around 3%, and in other rest of the parenchymal cells, it contains 6% of the iron. So even अलिकति चाहिन्छ तिमीलाई daily requirements like adult male is about 0.5 to 1 milligram. Female, because they are usually monthly menstruating, the requirement is a bit higher, about 1 to 2 milligram. Infants, children, and pregnancy, these are the you can say the demanding stage, right? Infants and children, these are the growing periods. So the growing periods, the demand increases, right? So that's why it should be usually 60 milligram per kg, and in children a bit less, 25 milligram per kg. Pregnancy, that's a high, especially in the last time. So iron is usually taken after 4 months, or from the 4 months, the iron tablets are usually prescribed. Iron supplements are prescribed, right? So the dietary sources, rich sources, these are the rich sources: the liver, egg yolk, dry beans, dry fruits, wheat germ, all these, okay, banana, apple. Whereas milk and its products and root vegetables, they do contain, but they are poor in content, right? So you look at it, so pharmacokinetic with iron. So iron absorption is usually it occurs in the whole, not usually, so that, but the major portion that absorbs the iron is duodenum, the initial part of the intestine, that is duodenum and proximal jejunum, right? So rest of the section of the intestine, usually it depends, right? If the iron store is low or the demand is high, the other segment of the other part of the intestine can also absorb the iron, right? So it's not that only duodenum and proximal absorbs the iron. So depending upon the iron status, oral parts layer, if you require more iron, then they can also absorb, right? Or in any anemic situation, let's say, the other segment may also be active, right? So dietary iron is present either as, you can see, heme iron or inorganic iron. So heme iron are those which are contained in the meat products, right? Whereas inorganic iron are other iron which are contained in other dietary products. So heme iron, there is a big difference between how heme iron and inorganic irons, they get absorbed, right? You can see here very high percentage of the iron are absorbed, right? But remember this heme, because meat is not always the major major dietary iron. So even 35%, even if 35% of the heme iron is absorbed, this usually is less in compared with the inorganic iron, because even if 5%, only 5% is absorbed, usually we don't take the meat always, right? So they were you point and so okay, now these are absorbed without having to dissociate into elemental iron, right? You can see picture me, so it's very clear. This is the heme iron, right? They get directly absorbed into the mucosal cells, GI mucosal cells. This is GI mucosal cells, all right? Whereas the This is the inorganic iron, right? Present in the diet. So inorganic iron, they are usually in the ferric form, and they have to be dissociated, or sorry, they have to be like reduced into the ferrous form, right, into the elemental, or basically these are present in other inorganic form, right? So they have to be dissociated from that, and then again reduced to ferrous form, and then get absorbed, right? So it takes a bit different steps, right? And the transporters for these are, so here it's not exactly shown here, I've shown in the another slide. So it should be a hem carrier protein here. Carrier protein चाहिँ चाहिन्छ है दुवैमा एक्चुअली, यो तिमीहरूको केटीमा देखाएको छैन. Hem carrier protein in for hem iron, whereas it is divalent metal transporter 1, DMT1 for this inorganic iron, right? So this is how the hem iron and inorganic iron absorption is, right? So as I told you, this is the same thing. Absorption increase in response to low iron stores and increasing demand. So with increasing demands, it can absorption increase. भनेको not only the other segments, because other segment पनि involved भयो, maybe that may be the reason, होइन? तर मैले 5% absorb हुन्छ भनेको छ, होइन? Usually 5% of what you take is usually सबै iron absorb हुँदैन. 5% of what you take is absorbed, right? But if demand increases, your 5%, it may increase to more than that, right? 10-30% may increase, right? With increase in demand, right? So now transportation utilization. Now you can see here, this is the hem iron, the ferrous iron has entered the mucosal cells, right? Now from the mucosal cells, depending upon the iron status again, whether it's high or low, it either gets entered into the circulation, it either gets entered into the circulation, or it gets like stored within the mucosal cell itself, right? So ferrous form here, you can see it is ferrous form here, entry bio, right? And if the iron status is high, let's say enough iron is present in the circulation for all those erythrocyte formation, then it will be converted into the ferric form again, and it will be stored in as a ferritin. So this is the apoferritin protein, right, to which the ferric form of the iron will bind, and it will form ferritin. So this is the storage form of the iron, and this is within the mucosal cells, right? But if it has to be entered into the circulation, then the ferrous form will move to the circulation, right? So always remember, it is the ferrous form that moves from here to there. So ferrous form यहाँ move भयो, and it is the ferrous form again which will be moving to the plasma, right? Whereas for storage, it has to be converted into the ferric. If it has to be circulated, then it will again be converted into the ferrous form. All right. So this is the protein now that transport the ferrous form into the plasma, right? So that is called ferroportin. So this ferrous form now enters into this plasma with the help of this protein in the basolateral membrane, right? And this ferrous form, again, you can see your movement again, it will be converted into the ferric form, right? So ferric form are converted by, and it will be now carried, right, or circulating with the help of this another protein called transferrin. Sorry. Okay. So transferrin is the protein that will now circulate the iron to different target cells, right, like the red blood cell, or to the other tissues like of reticuloendothelial cells like liver or spleen, right? So that they get stored here, right? Utilized here, stored here, right? So you can see here now the transferrin, for each transferrin molecule, there has to be two ferric residue, two iron residue, right? So two iron residue is carried by one transferrin molecule, right? Now this will transfer, this will move the iron to the target site, let's say to the erythrocyte precursor. Now in the erythrocyte precursor, or in each cells, actually, you can see here also, there are certain transferrin receptors, green color junde hasa, this is transferrin receptors, right? So which binds to this transferrin iron molecule, right? Now this transferrin receptor, now with the help of this transferrin receptor, they will be endocytosed, right? Endocytosed, and within the intracellular vesicles, right, at the pH of the this intracellular vesicles, all these three molecules will be dissociated. You can see here the transferrin, the receptor, as well as the iron, right? So the iron will be utilized for hemoglobin synthesis, and the rest too will be again translocated back to the membrane, right, for reutilization actually. Right, so this is how the transportation and utilization is being done. Now for storage, same process for storage. They will be, right, taken up by the reticuloendothelial cells, right, with the help of the same receptors, endocytosed, and then the iron will be stored as ferritin, right? So storage, now there is a regulation of iron stored, because depending upon the iron status, again, the iron is either stored or they will be utilized, isn't it? So for that, there is certain regulation of this iron. You can see here when low, right, transcription of apoferritin does not occur, right? Because our utilize hunu paryo bhane, it's not by like storing, by forming the apoferritin protein, storage protein, and then storing it is not relevant, isn't it? So it has to be utilized. So less apoferritin will be formed and more of transferrin will be produced. So all these are the gene level itself, right? So transcription of apoferritin does not occur, whereas the more transferrin protein will be produced, so that it can move the iron from the mucosal cells to from the plasma to the target site. Similarly, the receptor will also increase in the erythropoietic cells. So same, right? Very to the point. Low भएको बेलामा storage protein or कम हुने भयो, moving or binding protein or say it will be more, right? Similarly, when iron store is reached, more apoferritin or storage protein will be synthesized, so that the remaining iron is just stored in the reticuloendothelial cells and other cells, right? Okay, so one more regulation that which I have already mentioned. So these are all the how the iron status is regulated. So iron absorption increases or decreases depending upon the iron source. So increase enough छ भने iron absorption may even increase. Right. So one more type of regulation is there, which is a bit different, right? So that is called mucosal block or ferritin cortin, right? Now this is within the mucosal cells, right? So you can see that the iron which is absorbed at the mucosal cells, so they may either be stored or transported to the plasma depending upon the iron store. So what happens to this iron which are stored within the mucosal cells? So iron reaching inside the mucosal cell is either transported to plasma or oxidized to ferric form. Transported or oxidized to ferric form, right? And complex with apoferritin to form ferritin. Right? Now what happens to यसको fate के हो त? So the ferritin generally remains stored in the mucosal cells. Your storage form हो. If it is utilized, then that is utilized. Utilization भयो यसको, but if it's not utilized, then maybe it is lost like within 2 to 4 days with the mucosal cell itself, because mucosal cells commonly it has certain lifespan. So mucosal cells are usually shed off, right, along with the GI content. It is shed off, and along with that, mucosal cell shed off, along with that, the iron will also be lost. So how the mucosal cell is regulating the iron status? नचाहिएको iron चाहिँ यसले के गर्यो त? It is like excreting, right? So this is how the mucosal block. Okay, understood everyone? Not so difficult, So mucosal block, let's say, the excess iron, you can say, which is not required right by the body, is being shed off along with the mucosal cells. So this is how the mucosal block or ferritin curtain works. Right? Excretion is, you can if you remember the previous slide, the adult dose, right, about 0.5 to 1 milligram, right? So same amount is actually excreted. All right, so the daily intake is usually just to replace that the lost in different forms, right? So 0.5 to 1 milligram is excreted. The different route of excretion are, so one is mucosal cells, or J mucosal cells, then some red blood cells as a blood loss, and in bile also, right? And sometimes in desquamated skin and very little in urine and sweat, right? So through the skin also, you can say desquamation, it's like exfoliation. So exfoliated skin, the iron may be lost, very little amount, right? So these are different routes of excretion of iron. Now, so there are factors facilitating. Now, this is basically for the inorganic form of the iron, all right? So heme iron are usually not affected by the presence or absence of any other factors, right? But for this inorganic form of the iron, there are certain factors which facilitates the absorption and certain factors which inhibits or impedes the absorption, right? So you can see acid and reducing substances. So these are basically this favors dissolution and reduction of the ferric iron. So the ferric form has to be reduced to ferrous form, and it is the ferrous form that is absorbed. They were a ferrous form absorbed, ferrous form convert or any reducing substances like ascorbic acid and amino acid containing SS radicals. So these two will be like enhancing the absorption of the drug, right, or iron. And another is meat. Now, meat, one, it contains the heme iron itself. It's meat also induces HCl secretion, right? So by increasing the HCl secretion, and because you can see the acid, it favors dissolution and reduction into the ferrous form, meat also enhances this iron absorption, right? Whereas there are factors like alkalis, and just the opposite by alkalis will inhibit the absorption. Whereas phosphates, phytates, and tetracyclines, so these will actually, I have written here PPT, right? They inhibit the absorption by actually complexing with the iron, right? They form some complex, a larger complex with the iron, and that larger complex cannot be absorbed by the GI tract, right? Phosphates or phytates. Phytates are present basically in the plants, plant products, right? Like maize and all. And then tetracycline, the drug, and also presence of other drugs also inhibit the absorption of iron. So iron, it has to be taken in an empty stomach, right? But there are certain situations where you should avoid taking the iron supplements in empty stomach, like adverse effects also, GI adverse effects also. You may have to take the drug along with the food also, right? But we may have to increase the dose at that condition, right? But ideally, the presence of food usually inhibits the absorption, right? So different factors getting absorption. So now, pure pharmacology, there are very few things that you should that you have to remember, right? So preparations, so we have both oral as well as parenteral iron preparations, right? So oral preparations are usually the preferred route always, right? Because parenteral, when you go only, there are certain situations, right, where we have to go for, of course, because parenteral is obviously it's a vigorous route also, but oral preparation is equally effective as parenteral also, right? Right? So we have very popular, commonly available preparation, ferrous sulfate, ferrous gluconate, and ferrous fumarate, right? Now, ferrous, I guess you know by now, right? Commonly used, cheapen and better absorb ferrous form. So 32%, 12%, 33%, these are you salt form as so elemental iron, pure elemental iron, say you percentage is how so there are different you can say percentage of elemental iron in different preparation. 32% in ferrous. And तर यो सबै डोजमा पनि भ्यारी हुन्छ है, you just go for the dose. Actually dose पनि कति चाहिँ, right? So these are other preparations: colloidal ferric hydroxide, 50% of the iron is present, carbonyl iron, right? These are newer preparations, and these are the preferred route of administration. Okay, so we have other preparations as well. Different, there any preparations are the key yaad garnu paryo hai. I'm just showing you the slide. I'll skip this slide. Okay, you say these are actually the newer preparation thought to be better absorbed and produce less bowel upset. Okay, better absorbed and produce less bowel upset. So, but this less bowel upset, we have certain adverse effects. I told you, right, about with iron. Your less bowel upset with these new preparations is only at the risk of or risk or only at the expense of low composition of the elemental iron, right? Elemental iron may be comparatively lower than the previous iron preparation, and that maybe that is the reason it produces less bowel upset. So there is no actually advantage of these drugs. Okay, so now adverse effects. Now the main adverse effects, right? I'll tell you is the gastritis and constipation. Gastric pain, heartburn, nausea, vomiting, bloating, right? Staining of teeth with the oral, the liquid preparation or and metallic taste. There are different preparations available. There can be in the tablets, capsule, or slow release preparation or right? So depending on that, the metallic taste tablets or metallic taste or so gastritis and constipation important. Okay, one more you can add if you are noting down or diarrhea pani huna सक्छ यो आइरनमा चाहिँ. So some patient may also suffer from diarrhea, but remember constipation is the major adverse effects, right? So constipation is actually the is thought to be the, you know what astringent is, right? I guess astringent using tissue constricting capacity, so constipation may be because of the astringent property of the iron, whereas diarrhea is irritation effect of the iron, right? So both constipation pani huna सक्छ, diarrhea pani huna सक्छ. Okay, so parenteral preparations. Now, I told you parenteral preparations, they are recommended only in certain situations, certain conditions, like intolerance to oral iron preparations. And the patient, the major adverse effects like severe gastritis, he cannot tolerate and they may have to go for the parenteral preparations, or failure to absorb iron in conditions like malabsorption, inflammatory bowel diseases. And there is no use of giving the oral, no benefit of, it's not a good idea to give the drug orally. And in very severe deficiency, this is a very obvious thing, right? Severe or emergency conditions are always the indication for parenteral preparations, isn't it? And lastly, along with erythropoietin in patients with renal disease. Am I going fast? Fast way, Am I going fast? Fast way,
No, ma'am.
No?
No, ma'am.
Okay, severe deficiencies. So along with erythropoietin in patients with renal disease. So this is a situation you can see erythropoietin, and erythropoietin, it is synthesized from the kidney, and then in kidney diseases, if you are giving, let's say, erythropoietin for anemia, renal disease induced anemia, oral iron there, it's it will be like you can see here. Okay, oral iron may not be absorbed at sufficient rate to meet the demands of induced rapid erythropoiesis. Erythropoietin is a hormone that induces erythropoiesis, isn't it? Now, if you are giving the erythropoietin exogenously, especially, usually the pharmacological dose may be higher and a bit, of course, it may be a bit different from the physiological production of the erythropoietin, isn't it? So, pharmacological dose my erythropoietin, the erythropoiesis may be a bit rapid. isn't it? So that rapid erythropoiesis हुँदाखेरि चाहिँ oral iron दिँदाखेरि चाहिँ it may not meet the rate, isn't it? So the absorption may not meet the demands of the induced rapid erythropoiesis, right? So because absorption takes time, and in that process, so it will like it will unmask the iron deficiency zones. You know, the process, the machine is going fast, but you are, it's like the machine is working fast, but you are giving giving your raw materials, your products in a slow rate, isn't it? So it will like unmask the iron deficiency with oral iron preparation, right? So that's why in that case also parenteral preparation is given, right? So these are the parenteral preparation: dextran, iron sorbitol, citric acid, ferrous sucrose, and ferric carboxy maltose. Right. So now if you notice here, you can see all of these are organically complex formulation. Dextrans, सबै कार्बोहाइड्रेटसँग like complex class. Dextran, sorbitol, citric acid, sucrose, carboxy maltose. So usually the idea is because when you free iron, you just remember that free iron is always toxic, right? Free iron, it's toxic, right? So the oral iron preparations, so they are usually in ionized like salt form, isn't it? So in that salt form of the oral preparations are like the salt form, like see, it usually is thought to precipitate different proteins, right? So oral iron parenteral preparation is not a good idea. So that's why the parenteral preparations are usually complex, right? Organically complex, right? So now for parenteral preparation, म अब यसमा डिटेलमा जान्दिनँ, just few things like which is important for you to know, that iron dextran can be given both intramuscularly as well as intravenously, right? Whereas iron sorbitol citric acid is given only intramuscularly, and they have high affinity to bind to transferrin, right? So त्यही भएर पनि IV नदिएको है, because if you give this sorbitol citric acid intravenously, so the transferrin may saturate very quickly, right? And free iron may be like increase, right? And leading to toxicity, right? That's why these are given only intramuscularly, right? Ferrous sucrose is given only intravenously, whereas carboxy maltose also only IV. So it's very easy to remember. Dextran both IM IV, sorbitol only IM, and the rest only IV. This cannot be given intramuscularly, right? Another thing that you should be knowing about intramuscular injection of dextran is that they are given using a jet track technique once in the gluteal region, right? So bit of तिमीलाई थाहा छ होला, I don't know how तिमीलाई यो पढाइ हुन्छ कि हुँदैन, just तिमीलाई आइडियाको लागि अहिलेको लागि. So jet track technique is given in this way, right? So it's given usually in the gluteal muscle, like perpendicularly दिन्छ, but for that, right, before injecting the iron, you can see here the skin and the lower portion of the skin, the cutaneous regions, they are usually a bit pulled towards yourself, right? So it is pull direction there, pull गर्दाखेरि चाहिँ, and if you give the drug, if you inject the drug, then and if you leave the again छोडेपछि के हुन्छ त, you can see here the drug is inserted in a Z track technique, right? You pull गरेर perpendicularly inject गर्दाखेरि चाहिँ the drug, it finds a track which is in a jet shape. त्यसैले यसलाई jet track technique भन्छ, right? This is thought to be a bit less painful, right? And also to avoid the staining and all in the tissues, right? So Z track technique is good for you yourself. So now parenteral preparations for adverse effects. Of course, pain at injection site and pigmentation can occur, right? Whereas systemic effects are there like headache, fever, arthralgias, nausea and vomiting, back pain, and flushing or so urticaria, the hypersensitivity reactions and bronchospasm and anaphylaxis can occur, and even coma or death can occur, right? So especially you पछि गएर, okay? So usually before giving the drug, right? There is usually a practice of having a test dose, right? Test dose for this to determine the hypersensitivity reaction to the preparation, right? For parenteral preparation. So uses of iron now, of course, it is used for both treatment prophylaxis in the treatment and in the prophylaxis. So treatment, you can mention the cause of the anemia. It can be nutritional deficiency. Even in chronic bleeding also it is given. The malaria, right? The anemia induced after the chronic malaria, repeated malaria, you can suffer from anemia, right? Or in any inflammatory diseases, chronic inflammatory diseases. So these are the conditions where any iron deficiency anemia can occur. And you have to like look for the optimum response also, right? Which is seen by, right, rise in hemoglobin level by 0.5 to 1 gram per dl per week. So weekly, right, rise in this amount of hemoglobin is an optimum response. If there is no optimum, if there is no this not this amount of response, then you may have to increase the dose also, right? So prophylaxis भइहाल्यो, pregnancy and infancy, and also lastly in the megaloblastic anemia. Megaloblastic anemia मा किन, right? Like अघि हामीले डिस्कस गरेर erythropoietinमा भने जस्तै हैन, iron deficiency may be unmasked. Iron deficiency may be unmasked by brisk hemopoiesis induced by vitamin B12 or folate therapy. Folate therapy, right? So erythropoietin दिँदाखेरि हैन ब्रिस्ट हिमोपोइसिस भएको जस्तो यु आर गिभिङ लाइक से लेट्स से मेगालोब्लास्टिक एनिमियाको लागि भाइटामिन B12 र फोलेट थेरापी दियो, राइट? सो इट्स लाइक दुईटा प्रिपरेसन, दुईटा इन्ग्रेडिएन्ट्स दियो एन्ड देयर इज इट विल लाइक अनमास्क द डेफिसियन्सी अफ द अदर डेफिसियन्सी. त्यही हो कुरा आएको जस्तो है. यसमा केही छ कन्फ्युजन? Right, so usually, in fact, the iron, vitamin B12, and all these may actually go together. Iron supplement you may find vitamin B12, vitamin B12 as additive supplements in some preparations, right? So that is the reason. Okay, now a bit of poisoning now, acute iron poisoning. Now this, of course, usually occurs when you take like more than, depending on the patient's tolerability, like 10 to 20 iron tablets can actually cause toxicity. Especially in children, adult a bit higher dose only may cause the toxicity, right? And this is of course usually accidental case. So infants and children, if they take the tablets that you leave on the table, so these are the manifestations. Manifestations: vomiting, abdominal pain, after increase in like hemopoiesis. So vomiting, abdominal pain, hematemesis, blood emesis, blood vomiting, and then diarrhea, lethargy, cyanosis, dehydration can occur, convulsions, shock, collapse, cardiovascular collapse, and death. Right. So cardiovascular, this CV collapse and death may not occur immediately, but like the patient may show some improvement in response, but ultimately they may collapse and the patient may even die, right? So one more thing okay, so these are the different manifestations about usually it may occur within 6 hours, right? But in some patients it may like take 12 to 24 hours, right? 12 hours or more. So, or to cause death, let's say, right? Koike patient or 6 hours maybe they may collapse, or whereas some patient they may take more than 12 hours, right? So the treatment, now treatment, general measures भन्नाले I'm not discussing here general measures भनेबित्तिकै all these conditions to treat the vomiting, the hematemesis, the dehydration, you are giving the salines and all, right? And even acidosis so you may have to like give the drugs to improve the acidosis, right? Now, but particular treatment that you should be knowing is, right? Remove the unabsorbed iron. एउटा unabsorbed iron को लागि र एउटा absorbed iron को लागि एउटा strategy चाहियो हैन. So for unabsorbed iron we can go like vigorous vomiting गराउन सकिन्छ, induce vomiting or gastric lavage with sodium bicarbonate to render the iron insoluble. So basically vomiting भन्दा you can go with this sodium bicarbonate, right, like whole GI irrigation गरे जस्तै, and to render the iron insoluble and remove the unabsorbed iron, right? So this is usually practiced. Or even if you are at home, then egg yolk or milk can be given, right? Now this is to complex the iron. And egg yolk, milk, or let's say they can form complex with the iron and inhibits the absorption of the unabsorbed iron, right? Now remember, I don't know how far you have, how many types of poisoning you have like completed till now, right? Usually activated charcoal is one of a right practiced thing, all right, to prevent the absorption of the poisons, all right. But in case of iron poisoning, activated charcoal is activated charcoal, they do not absorb the iron, so it's not of use in this case, right? Okay, now this is for the unabsorbed iron. Now for absorbed iron, we are giving the desferrioxamine, or this is the antidote to the iron toxicity, all right? Desferrioxamine or deferrioxamine, you can write anything, all right? So this is a potent iron chelating compound. You know what chelation is, I know. Again, it's a complex formation with a potent iron chelating compound, just let's say a chelation with the chemical reaction, chelate गरेर चाहिँ they form a larger compound, right? Larger iron compound, and hence it will inhibit the transfer of the or binding to the other tissues. We already absorbed iron ko कुरा हो हैन. So these are given intramuscularly or intravenously, right? This पनि दिन सकिन्छ to bind iron that has already been absorbed and to promote its excretion in urine and feces. Okay. So desferrioxamine, already absorbed iron ko लागि, the mechanism is chelation and given intramuscular or intravenous, right? So that once it binds, once chelation is formed, right, it will like further binding to other tissues. It can bind to other the heart tissues and then the liver, that the further organ damage or say prevent. Right? Lastly, diazepam if convulsion is present. Right? Convulsion भनेको you know, right? Epileptic patientहरुमा देखिने, so convulsionहरु भयो भने चाहिँ diazepam can be given. All right? So that's all. Vitamin B12 we will continue tomorrow. Right, on next. ठीक छ? केही छ question?
No, ma'am.
Okay, केही छ भने सोध्ने है. Okay, next will be यति होला. Okay, then we'll meet in the next class. केही छ भने सोधिहाल्ने. Okay then.
Thank you, ma'am.